Thank you very much, and I'd also like to reiterate my thanks for being invited to speak today, and privileged to speak to an audience such as yourself. I'm aware that sometimes we give talks aimed at other doctors and sort of allied health staff, and so I hope my slides aren't too complicated. So I'll try. If there's any particular aspect of any of my slides or the graphs that aren't clear, then I'm happy for someone to indicate, and I'll explain in more detail. Now, Chris already spoke this morning about the GLP-1 class of drugs. And, of course, this whole session is about innovation and new developments in type 2 diabetes. And it's no surprise that I'm talking about the SGLT2 inhibitors, because basically these two classes of diabetes drugs have revolutionised our treatment of type 2 diabetes over the last sort of 5 or more years. So if I go to the next slide. So to get you into the mood, I'd like to start off with a very simple case. To illustrate my opening point. So imagine I'm been asked to see a 68-year-old man, and his past history, he's had a heart attack, he's overweight, his body mass index, which we've referred to before, is 35, he's on treatment for blood pressure, for cholesterol, and he's got stage 3A kidney disease. So kidney disease is sort of grouped from stage 1, which is pretty good, to sort of stage 5, which is dialysis or transplantation, and he's stage 3A, so he's sort of in the middle. Now, his GP refers him to see me. He's had diabetes for 8 years. He's on metformin, which is almost always our first choice. And he's tried to follow all the lifestyle measures in terms of diet, weight loss, exercise. But despite all these efforts, his diabetes control isn't very good. His hemoglobin A1C is 9.5%. And as Chris explained earlier, and I think as a lot of you would understand, that hemoglobin A1C is the measure that we use to see what diabetes control has been like over the last sort of 3 months. Normally, we aim for around 7%, but we individualise targets depending on patient characteristics. So people who have longer-standing type 2 diabetes with heart disease, we might aim for 7.5%. But someone who's just been diagnosed, if we can get them closer to 6 without causing low blood sugars, then that's what we aim for. But clearly 9.5% in whatever way you look at it is way too high. Now, he's already on other treatment for his other comorbidities like blood pressure and his cholesterol. So what would I do? Now, to illustrate my point, imagine I saw him in 2002, which is when I first started practicing as an endocrinologist. So I completed all my training, and what was available to me at that point? So basically, I would have added in a sulfonylurea class of drug, and I'll refer to this briefly in a minute, and that might have been something like gliclazide or dimicron or similar agents. I would have kept him on the metformin, sent him away, said come back in 3 months, and what would have happened in 3 months? So typically his hemoglobin A1C may have improved to 8.5%, but it's still above target. Now, in 2002, when I was starting out, what could I have done at that point? And really, there's not much else I could have done other than start him on insulin, because that was really what was available to me at that time. Now, insulin would clearly have been effective, and it still is very effective, and we use it very often. And nothing I say here should indicate that should discourage people from insulin if that's the appropriate medication. But it would have had some drawbacks. I would have acknowledged that he may have gained some weight, because that's a common effect of insulin in type 2 diabetes. And it would have increased the chances of low blood sugars, because if insulin will work no matter what your blood sugar is at the time. So if your blood sugar is good, but you're still on a regular insulin dose, there's a slightly higher chance of low blood sugar. However, now in 2020, these are all the classes of drugs I'm not even mentioning insulin there, but these are all the classes of drugs available to me for type 2 diabetes. So in each individual class, there's about 3 or 4 medications. So there's multiple medications. Now, I'm using the laser pointer, and I'm aware that I'm pointing to this screen, but it won't show up in the other screens. So if possible, if you could look at the middle screen for whenever I use the laser pointer. So I could have added in the DPP-4 inhibitors. Now, Chris already mentioned that those are typically drugs like Januvia or Tradjenta, which you'll recall inhibit the inhibitor which causes the GLP-1 breakdown. I could add a SGLT2 inhibitor, and I'll spend most of my talk talking about that class. I could have added the GLP-1 analogues, and these are some of the drugs, and Chris has, of course, spoken in great detail about that. I could have added acarbose, and I could have added the glucagones like Actos and Avandia. So these are all, these extra 5 classes, besides metformin and the sulfonylureas, which were available in 2002, are all new. This has all come in since I've completed my training. So this shows how the landscape of diabetes has evolved, so much in the last, 18 or so years. So if I just very briefly take you through the classes of diabetes drugs, and then I'll focus on the SGLT2 inhibitors. So biguanides refer to metformin. That's the only drug of its type, of its class in Australia. And that basically works on the liver. So, So that basically works on the liver. And it works by reducing glucose production from the liver, and it helps some of the glucose which is in the bloodstream gets distributed to other tissues as well. The sulfonylureas I've already mentioned, those are like gliclazide, dimicron, and they basically work on the pancreas. They sort of squeeze out the insulin from the pancreas, if you like. Then there's acarbose. That was actually sort of available in some situations already when I started, but it's a little bit more common now. Now, that works by inhibiting carbohydrate absorption from the gut. Now, it's quite an effective drug. The only problem is many people who have it or take it get sort of side effects. It upsets their stomach, so it's often not a very popular choice. Then there's the glitazones, and these work on on various sites, but including on sort of fat cells and muscle cells, and help glucose uptake in those cells. So the 2 drugs we have available here are Avandia and Actos. Now, we don't tend to use this class of drug very often now, because although they're very effective in terms of improving diabetes, the one of them, Avandia, that Chris alluded to earlier, was the one that had the scare with the one analysis suggesting an increase in heart disease on people taking that drug. In addition, it doubles fracture risk, so that's not a sort of optimal drug, and there's a few other, also can cause quite a lot of weight gain. So we don't tend to use that class that much, but it's still available and useful in certain circumstances. Then we've got the GLP-1 analogues. I won't labour the point because Chris discussed that earlier, but they're a very useful class of drugs working to reduce satiety and on slowing gastric emptying and increasing insulin secretion. And then we've got the DPP-4 inhibitors, which sort of help one's own GLP-1 to work better. So what I haven't showed here is a class of drug which has been introduced in Australia in about 2015. And that's the SGLT2 inhibitors. So they work on a completely different site. They work on the kidney. The other drugs, this slide shows them in a different way, the sites of action in the different parts of the body. So I think I'm going to now talk about the SGLT2 inhibitors, but what I'd like you to take from this is we now have 6 or so classes of diabetes drugs, and they all work synergistically. They all work together. So that's why when you see your doctor and they start one drug and it doesn't seem to be quite effective, they don't take it away often and replace it with something else. More likely, they'll add it. So you'll still stay on this, but you'll add a second drug or third drug, because each drug still works, but it may not work sufficiently. And because they all work on different sites, that's how they get their complementary method of action. So this is the title of my talk. Now, I'll just be saying SGLT2 inhibitors, but they stand for sodium glucose cotransporter 2 inhibitors. That's the full title, and I'll show you why that's the case. So this might look complicated, but I'll try and explain it in simpler terms. So this is the nephron. So there's thousands of these in your kidneys, and this is how our waste from our body end up in our urine. So basically, there's small blood vessels or capillaries going into this the top of this nephron, which is this sort of cup bit, and then some of the waste from the blood cells get transported through this tubular system. But along with some of the waste, water goes through, as well as some other chemicals in the body, such as glucose, sodium, potassium, magnesium, and other things. Now, we obviously want all the waste to be excreted, but we want to preserve some of the stuff that we need. So although this goes through, all the stuff goes through the nephron, along the way, along the circuitous way, a lot of the stuff gets resorbed back into the bloodstream. So surrounding these sort of tubules, there's a whole sort of mesh of capillaries which absorb some of the stuff that we need back. Now, normally, if we don't have diabetes, there would be no reason why we would want to lose glucose through the urine. So the way that our body works is that 90% of our glucose gets reabsorbed in the first part of this nephron back into the bloodstream, and then another 10% gets absorbed further down this nephron. And then the waste which are left, along with a bit of water, comes out the end, and then thousands of these, grouped together, and then lead into your ureter, which goes into your bladder. So that's what normally happens. But if I look in more detail, so again, this looks complicated, but I'll try and simplify it. If we look at the nephron, this yellow tube bit is is a cross section of the nephron which I referred to earlier. So the water and solutes and chemicals go through here and come out at the other end. Now, in the wall of this collecting duct, there's some receptors, and Chris discussed the issue about hormones and receptors earlier, and then these are the blood vessels through which it goes back into the body. Now, normally, glucose, which is coming out in your urine, gets absorbed back into your bloodstream. That's the normal thing which happens. So, about 20 years ago, some groups in the United States had the clever idea that maybe we can use this mechanism as a therapeutic avenue for type 2 diabetes, because if you have diabetes, then what if and you've got an excess of glucose, what if you can actually prevent the glucose from being absorbed back into your system and pass it down your urine? You'd be getting rid of a big glucose load that could potentially improve your diabetes control and also have some other effects. So what was developed was research was done on the SGLT2 receptor, which is what allows the glucose from the nephron to be absorbed back into the bloodstream. And the thought was, if we can prevent that receptor from working, and so this class of drugs called the SGLT2 inhibitors, so if we can prevent that from working, then that glucose won't be able to get back into the bloodstream and it will pass out into the urine. And that could be beneficial in type 2 diabetes. So that's in fact what, if you look at the lower bit, that's in fact what we've done. We've inhibited the SGLT2, so the glucose doesn't get absorbed back in and it passes out and eventually leads out into the urine. So what would be the consequences of that? So firstly, I'd just be interested, I'm going to show you a list of drugs. I'd just be interested with a show of hands whether any of you recognise any of these that you or your carers might be on. So I haven't even got to the next thing yet, but I can already see a few. So in Australia, we have 3 of these. There's probably about 10 or 12 around the world. The common ones are Forxiga, which is dapagliflozin, and Jardiance, which is empagliflozin. Those are the 2 most common ones of the 3. But they also come in different combinations. So you can get them by themselves, you can get them by themselves in different doses, or you can get them combined with other agents in the one tablet. So you can get them combined with a metformin. So like Zigdio is a combination of metformin and Forxiga. Jardiamet is metformin and empagliflozin. Or you can even have it combined with a DPP-4 inhibitor. So from basically another class of diabetes drug. And so we've got Quitern and Glixambi. And then more recently, ertugliflozin has been introduced, although it probably only accounts for about 1 or 2% of prescriptions in this drug class, because there's less sort of data showing its effectiveness beyond diabetes control. That's still an evolving area. There's still results of some of their trials to come through. So those are the classes of drugs. So do any of you, could I have a show of hands to see how many people recognise them? So we've already got a few people here on this class of drug. Now, the first criteria as an endocrinologist when we assess a diabetes drug is actually, does it work? Does it lower blood glucose? Because obviously if it doesn't, then we don't go any further. So I'm going to show you this slide. Now, this uses a drug. This is using an example of canagliflozin. So canagliflozin was briefly introduced in Australia in 2014, but then they had a sort of a quarrel with the PBS about the pricing of the drug. So the PBS was sort of trying to go for lower, and the company didn't want to go for lower. So they've actually withdrawn it. So it's not available in Australia. But I often use this slide just to show, to try and avoid bias. Although, of course, what I show with this applies equally to the other classes. So with canagliflozin, you can see that in this trial, where patients were followed up for 26 weeks, for half a year, and they started off at baseline, and then half the group got placebo, and then their hemoglobin A1C, their diabetes control, was followed periodically, every few weeks, 6 weeks, 12 weeks, 18 weeks, 26 weeks, and they were put on one of two doses of canagliflozin, which is called Invokana, and this was the lower dose, and that was the higher dose. Now, what this graph shows is, at each time point after the baseline, those on the drug kept having a drop in hemoglobin A1C. So this is the actual reduction in hemoglobin A1C. So if you, at the end of half a year, 26 weeks, on average, if you're on the higher dose of the drug, you lost about 1.2% in hemoglobin A1C. So if you started off at 9%, on average, of course everyone's different, some have a better response, some have a worse response, but on average you'd lose about 1.2%. So that's, it may not be the only drug that you need to use, but that's fairly handy, depending on where you're starting from. So we know it works. So we were happy about that as endocrinologists, and we were prepared to, look into it a bit further. But the other thing, of course, is insulin and dimicron in particular can cause low blood sugars, because they do work when even when your actual blood glucose isn't very elevated. However, this class of drug, the SGLT2 inhibitors, and I've just given an example with canagliflozin, in this study, there was actually no really significant difference in low blood sugar between the groups, the placebo or the people who took the drug. So in other words, if you take this drug, it works when your sugars are high, but it doesn't work when your sugars are like getting close to low. Now, obviously, if you're on this drug but you're also on insulin, well, then you could still get low blood sugars, but that's not because of this drug. But just by itself, it doesn't cause it. So that's handy, selling point. So we were pleased with those two things. And weight gain is often an issue for our patients with type 2 diabetes. So, as you know, sometimes there's underlying overweight, but in addition, some of our drugs in the past, like the glitazones, the sulfonylureas, and insulin, can actually contribute to weight gain, partly by the mechanism of action. However, there's modest weight gain with this class of drug as well. So that was a third good thing. We've got the no hypoglycemia, the fact it works with diabetes, but in addition, there's an average of about maybe 3 kilograms at the higher dose of weight loss. Once again, it's not it's not huge, but it certainly would be handy if you and everything counts. And most people who are overweight would take 3 kilograms of weight loss. So, more importantly, it didn't actually cause weight gain, which is, as I mentioned before, one of our other concerns. So that was all very good. So that in itself was enough for us to start prescribing this class of drug. As I mentioned, it was Forxiga and Jardiance, which were the main ones at the time, but that was already enough for us to get going. So, were there any other benefits? Well, there was another benefit as well. So it had an effect on blood pressure. So many people with type 2 diabetes are often on medications for blood pressure, and often they need, several medications to get their blood pressure at target. Now, at the higher dose, this class of drug dropped the systolic blood pressure. So that's if your GP checks your blood and it's 150 on 80, so the 150, that's the systolic blood pressure. It drops that by about 5 on average. So again, that's handy. It may not be enough to get you off all your blood pressure drugs, but that's still a handy addition. You're not taking an extra tablet, you're taking a diabetes tablet, but it's still doing this as well. So that's a further benefit. So by this stage, we were very happy with this class of drug, and it was starting to be very widely prescribed. So we know that it lowers glucose, helps weight loss, reduces blood pressure, does not cause low blood glucose. We would have settled for that, but were there any other benefits? And of course the answer is yes. So this article came out in the New England Journal of Medicine, which is probably the sort of major general medical journal that physicians look at. And in about 4 years ago, this trial came out. So it all came out of the original need to do the safety trial. So you remember Chris mentioned earlier that the FDA mandated that all new diabetes drugs had to be proven to be safe. Well, not only did they prove to be safe, they actually proved to have a cardiovascular benefit. So in this trial, it was a double-blinded trial. So you had two groups of people. And you had the people taking the drug and the people who didn't take the drug, and the patients didn't know which one they were on because the placebo and the drug tablet looked the same, and even the doctors treating them didn't know which drug they were on. So there was no sort of reason to suspect any sort of bias. And there were, it was done as a worldwide sort of thing with 590 sites around the world. There were about 7,000 patients, and about a third were on a placebo, and a third were on the lower dose of the drug, the 10 milligrams, and another third were about on the a high dose of the drug. And what they looked at is what cardiologists like to call MACE, which is a combination of three things from a cardiology point of view that interest them. It's your occurrence of cardiovascular death, that's obviously pretty significant, or a heart attack, even if you don't die from it, or a stroke, even if you don't die from it. So these are considered hard endpoints. I mean, if you can prevent these sort of things, that's a good thing to do. So in this trial, there's two graphs here. So the first one's the placebo. So what that shows is starting off from time 0 up to 48 months, so about 4 years. And at each time point, they look to see what the risk of getting the percentage of their patients in that particular cohort, whether it's placebo and treatment, developed the primary outcome. And looking at a combination of all the things, you can see that by the end of the trial, about 15% of people in the placebo group got an event after 4 years, and much less, maybe about 11-12% got on the empagliflozin group, the Jardiance group, got the cardiovascular event. So, I mean, that's quite a significant. If you look at the actual risk overall, that's quite a big reduction overall, and it's comparable to the sort of effects we see with other treatments for heart disease, like in certain situations cholesterol drugs or beta blocker drugs, which cardiologists use. So this was almost like a cardiology drug now, and then. If we look at in more detail, if we look at death from cardiovascular causes, there's a big gap between the two. The people in the placebo group got a much higher percentage of death from cardiovascular causes than the empagliflozin. And interestingly, you will notice that the two lines actually start to diverge quite early on. So it's not something which is a late benefit. The benefit starts accruing quite early on in the piece. Certainly you can see it by the 6-month mark. So this was very exciting. This trial was only done to show it wasn't harmful, and now we're starting to see cardiovascular benefit. And then, and if you look at heart failure, there's even a bigger difference between the two. So this was using the drug Jardiance, which is empagliflozin. I should also add that the other drug in Australia, Forxiga, which is dapagliflozin, also has been shown to have this sort of benefit in heart failure. In fact, just as an aside, I know I'm talking at a diabetes essay seminar, but it actually works to reduce heart failure even in people without diabetes. So that was very exciting. So I had all those benefits of the drug, and then now we've shown cardiovascular benefit. So that's an extra plus. Then at the same time, the people who were looking at canagliflozin reported on one of their trials, and this time it was looking at kidney disease. You remember that my case that I presented earlier, the guy that I was treating had stage 3A kidney disease as well as a previous history of a heart attack. So in this trial, there were about 4,500 patients with type 2 diabetes with stage 2 or 3 kidney failure, and half got this drug, canagliflozin, and half got placebo. And again, you're looking at the same sort of way. The kidney doctors are very interested in these sort of things. So obviously, death from kidney failure, that's pretty important to them. That stands for end-stage kidney disease. So that means ending up on dialysis or needing a transplant. That's a pretty bad thing to get. Or doubling of serum creatinine. So creatinine is one of the markers of your kidney function. If it goes up, that means that things are getting worse. So if that doubles, that's not a good thing. So looking at all those sort of endpoints, you can see that there's, again, compared to the people on placebo, by the end of the 42 months, had a much higher risk of getting those bad things than the people on the drug. So now we're seeing a diabetes drug which has all those benefits in terms of diabetes that I mentioned, but it's also having a positive effect on the heart, and it's also having a positive effect on the kidneys. Now, these trials weren't sort of some fluke, because several of these have done several trials, and not only that, there's been different classes of drugs, different drugs in the same class, and they've all shown a similar sort of pattern as well. So it's something about this class of drug, we think, that is very beneficial. So this looks like a very complicated slide, but essentially this looks at your chance of getting those bad kidney things. So if you, this line that goes down the middle, if anything's on this side of the line, it's bad. That means your risk is higher than placebo. Anything on this side of the line is good. That means your risk is less. So, for example, getting end-stage, kidney disease, you might have a 70% chance of getting it compared to someone who's not on the drug. So with all of these sort of bad kidney things, the outcome for people taking this class of drug is quite favourable. So for this reason alone, the prescription rates of this class of drug have sort of exploded around the world. So not just in Australia, but the US, Europe, Asia. In Australia, this class of drug, I believe, is now, in terms of endocrinologists, is the most widely prescribed after metformin, which we usually still start with. It's because of all these extra benefits. Moreover, now, even cardiologists and renal physicians are now interested in starting these drugs. Because it's a diabetes drug, sometimes they're reluctant to start it themselves, but usually they'll write a note to the GP, or if there's an endocrinologist, saying, well, look, do you think that we can start this class, because we would like it from our point of view. So just to look at just to summarise the benefits again, looking at Jardiance, but it applies to Forxiga as well. It reduces hemoglobin A1C. It depends what level you're starting with. So if you're starting at a high hemoglobin A1C, you have a better reduction, but it can be anywhere from about 0.7 to 1%. You lose weight, depending on the trial, can be anywhere from 2 to 3 kilograms. You lose you have improvement in blood pressure. You prevent cardiovascular death. You prevent heart failure, and you improve or reduce your chances of getting a bad kidney outcome. So that's all the good stuff about this class of drug, and why we are very excited about it. And this slide just sort of summarises what I've just shown you about different parts of the body and the improvement. So if we think about it more globally or philosophically, In the past, we were looking at glycemic control, that's the glucose control, as overlapping with perhaps with obesity a bit. And so, we're targeting obesity, to losing weight to improve glucose control. But the issue about the lipids and the high blood pressure and everything else was quite separate, like a separate problem to be tackled separately. Now what we're seeing, if you look at the circles on the right side, is that these drugs which improve glucose control also overlap with not only with obesity control, but also with other things like blood pressure or other metabolic sort of parameters which affect your heart and kidneys. So we've got, it's now arguable whether we could say this is a diabetes drug or whether it's a sort of metabolic drug which has multiple effects. So that sounds really good, and I personally have a very low threshold to initiate these class of drugs in people who are suitable. So remembering that this is just for type 2 diabetes, not for type 1 diabetes. But it would be very important for me to point out where we wouldn't use it. So it's not actually proven in people with more advanced kidney failure, so type 4 or type 5. So we use this thing called the estimated GFR, which is on one of the blood panels, and if it's that can sort of range from 90 down to about, if you're down to about 10, you're usually on dialysis. If it's below about 30 on that, then we question whether it'll be effective. Certainly below 40, below stage 3 kidney disease, it probably doesn't work well in terms of reducing glucose control. However, it may be that there's a certain portion of kidney failure where it doesn't work for glucose control, but it still works for those other things like preventing further worsening of kidney failure or preventing heart disease. But it's not, in terms of diabetes control, it's not proven. It doesn't mean it doesn't work, it's just not proven yet. Obviously, because it lowers blood pressure, if you have someone who starts off with very low blood pressure for whatever reason, you have to be a bit careful, particularly if you get postural hypotension, your blood pressure drops when you stand up. I've written avoid. I suppose I probably should have said be cautious. Because of the potential to dehydration, if you had someone who was prone to dehydration, who had perhaps had a history of bad kidney stones, I might be a bit circumspect about using this class of drug because we know dehydration's important in the causes of kidney stones. The most common reason why I end up stopping it is because of this urinary infections and thrush. So you remember how this class of drug works? It works by causing you to basically excrete more glucose in your urine. So if you're someone who's prone to getting urine infections or thrush, then with all that glucose, in simplistic terms I suppose, if you have all that glucose passing through your kidneys and your bladder and you've got a few bugs there, they're more likely to multiply and cause urine infections. So if you're someone who's prone to getting that, I would be careful about using it. I wouldn't say I would never use it, but if you were getting 2 or 3 urine infections or getting thrush a couple of times a year, I probably wouldn't use it. If you had an episode 20 years ago, I'd probably overlook it. But I always would warn people about that so that they can watch for it. And I would estimate, maybe in practice, 10 or 15% of people stop the drug for that reason. It seems to be more common in women. In men who are circumcised, they're modestly protected, for what it's worth. So that's an odd question, but I always ask my patients that my male patients that when I start this drug. The one other very rare side effect, but it's very serious side effect, is what I'm going to now talk to you about, and that's diabetic ketoacidosis. So does everyone here or anyone here know what diabetic ketoacidosis is? So we normally think about diabetic ketoacidosis with type 1 diabetes. So normally I'd be in the other room speaking about diabetic ketoacidosis, not in this room. It's very rare in type 2 diabetes, except in people who are extremely sick. It's much more common in type 1 diabetes where if for whatever reason insulin's not taken for a couple of days, you can develop it. Usually in diabetic ketoacidosis, and I'll explain a bit more about it in a minute, the blood glucose is high. In this condition, we call it euglycemic diabetic ketoacidosis, which is just a fancy way of saying the actual glucose may be okay, may be normal, but you still get diabetic ketoacidosis. So the first point to make is in clinical trials with this drug, this side effect rarely showed up at all. But that, in retrospect, that's not at all surprising because in clinical trials, people are very closely monitored. People the investigators don't want the trial to fail, so they're ringing you up every week, checking that you're okay, particularly early on. And so this sort of thing would be picked up very early. So it's not surprising at all that it wasn't really appreciated at the time when the initial trials were done. Moreover, this is a drug for people with type 2 diabetes, so we wouldn't normally expect it anyway. Just to explain, so ketones are chemicals that are acidic that are produced from the liver from fat breakdown. Now, they're actually an energy source, an alternate energy source to glucose. So some of you may have heard of diets which are ketogenic diets. That's where you sort of starve yourself of carbohydrates, and so your body goes into ketone production. It's a similar sort of mechanism. And producing ketones can be associated with starvation or fasting, alcohol excess, or in people who need insulin, inadequate amounts of insulin, so either not taking it or taking much less. Typically that might occur in someone who's sick, who is on insulin, who perhaps doesn't feel like eating very much, and so they make a decision themselves, which may not always work out to be the best decision, but they make a decision because they're not eating to then not give themselves the insulin, and then of course they make themselves more prone to this situation. In that situation, if they can't keep food down, they probably should instead have gone to hospital where they can get glucose given intravenously so that they can still get the insulin that they require. But in any way, so in diabetic ketoacidosis, you get high acid levels in the blood, and that's due to an increase in the amounts of these ketones. So this is a problem normally in type 2 diabetes, but in SGLT2 inhibitor patients, this can actually occur spontaneously. So it can actually occur not necessarily when you're ill, although usually it's associated with illness. It can be associated with illness, a poor appetite, fasting. Particularly, it can occur in people who are getting ready for surgery, particularly heart surgery and abdominal surgery and a surgery for weight loss. And it can be associated with conditions like missing insulin if you normally need it. We recently published a study of people actually in the Queen Elizabeth and the Royal Adelaide, and with a colleague in Brisbane, of 8 cases just occurring over a period of the last year, where people who were taking bowel prep for colonoscopies, who hadn't stopped this class of drug, actually developed this condition as well. So the way that this actually occurs, this ketoacidosis, is if you start off at the kidneys. You remember that because we're not now excreting glucose, because you are excreting glucose, the blood glucose levels drop, and that sort of then has an effect on the pancreas. And what this would normally do is decrease whatever normal insulin production you would make from your pancreas, and would increase the counter hormone, glucagon, which Chris referred to earlier. This can be worse in situations of medical illness, medical stress, or surgical stress. The combination of this can lead to muscle breakdown and fat breakdown, and these breakdown products go into the liver and form these ketones. And moreover, normally these ketones are excreted in the kidneys and into the urine, but there's some evidence that if you're on these SGLT2 drugs, that it's actually absorbed back into the bloodstream. So that's another mechanism as well. So the combination of all of this leads to build up of these high ketone levels, which causes a raised acid level in the blood. So my interest in this started when it was the end of 2016, and I was on call at the Royal Adelaide and the Queen Elizabeth Hospital, working with one of our registrars, who's now a consultant, Emily Meyer, and we were starting to see a lot of these cases. So, like within about 1 week, we had 3 cases coming in of people, because this drug class had just taken off because of all the good stuff that I've been telling you about earlier, and we saw 3 cases come in a period of a week where this diabetic ketoacidosis had occurred. So, I mean, we weren't by no means the first people to ever describe this. This was described in the United States about a year and a half earlier. But we suddenly thought, it's not actually very well publicised in Australia. So in a short period of time, just looking back in a year, we picked up about 14 cases from South Australia and about 300 cases reported to the TGA, the Therapeutic Goods Administration Authority, of this condition occurring. And we tried to work out what some of the common features of the patients who got this condition were, and we ended up publishing it. And that sort of sparked our interest in this area. We then, I think that's a duplicate slide. We then did a review of what had been published around the world about the people who get this condition when they're about to have surgery. Because you remember I said that people in the perioperative time frame, so leading up to surgery and during surgery, are also, who are on these drugs and who don't stop these drugs, are at higher risk of getting this diabetic ketoacidosis. So we did a review of what had been published around the world, and we found that the risk factors for getting this around the time of surgery were if you had been misdiagnosed as type 1 diabetes. Now, that sometimes can happen because type 1 diabetes doesn't just occur in people who are young or adolescents. Occasionally, it can present, in later life. You might be 60 or 70 and get it. It's rare. Almost always that's type 2 diabetes, but it could be type 1 diabetes. And so if someone had been labelled as type 2 diabetes and type 1 and were put on this drug, that could then precipitate ketoacidosis, which itself normally occurs in type 1 diabetes. If you're having certain types of surgery, like obesity surgery, where it's not just the surgery, but you usually for about 2 to 4 weeks earlier go on a very special low-calorie diet, which can be ketogenic in itself, then that was a big risk factor. If you're having cardiac bypass, that was another, the stress of having that can do it. Abdominal surgery, so anything which affects your gut and causes your gut to sort of slow down at the time of surgery, that can do it. If you have kidney failure, that's another risk factor. And possibly, but not always, if you had poor diabetic control. So we looked at some of the characteristics, and this is just a table from an article we published when we looked at the data from around the world, and essentially it doesn't sort of favour males or females particularly. There's an incidence of a few people who are misdiagnosed, but you'll see that the average hemoglobin A1C was 8.3%. So whilst it's not perfect, it's by no means sort of disastrous that only the people with very terrible type 2 diabetes get it. It's actually something which anyone can get. We had people with hemoglobin A1Cs of 7% and 6.9% who got that. We also found that, as I mentioned, that bariatric surgery, abdominal surgery, cardiac surgery were risk factors. So in many cases, there were as I mentioned, there were other things which contributed. So some, particularly if there was associated dietary modification to do with preparation for the surgery, if there was changes in medications, if insulin was stopped when they needed it, these were all risk factors. So we then embarked on a sort of a program in our area in the Royal Adelaide and the Queen Elizabeth Hospital to try and prevent this, and by looking at some of the risk factors that I've already mentioned. And that's why hopefully when any of you who are on this class of drug, when you start it, hopefully you'll be just advised about what to look for, because by no means would I want to discourage any of you from taking this class of drug if you need it, because it's so useful, but you just be aware of this very rare side effect and what to watch for. We also advise patients, depending on the type of surgery, to stop taking it a few days prior, so up to 3 days prior in some cases, depending on the type of surgery. We've developed fact sheets, which can be, it's available through SA Health, and we give to our patients at our hospitals. As a result of this work and work from overseas, the Australian Diabetes Society have also put out some fact sheets for patients, so that for providers, but to tell their patients about what to watch for and with diabetic ketoacidosis with this class of drug, because they were well aware of the explosion in prescriptions with these drugs. So what I would say to any of you who are here who are taking these class of drugs is, if you're going in for any surgery, then you may need to stop it For very minor surgery, you might just stop it a day before, but for major surgery, particularly the ones I mentioned, you need to stop it at least 3 days before the surgery. So it's sort of well out of your system and not likely to cause this problem. Now, of course, this could lead to other problems because if you stop the diabetes drug, and particularly if you're on this drug in combination with a second drug and you stop both of it, your blood sugars could go up, which is not a good thing to happen before surgery. So you would need to discuss with your, your doctor what you need to do. There's been advice given to hospitals that if people haven't been able to stop the drug because they weren't aware of it or whatever reason, then ketone levels can be checked, and that can be checked but with a simple finger prick test. And if that's elevated, then if it's elective surgery, not emergency surgery, then it might need to be cancelled. Otherwise, a close eye would need to be kept on your acid levels and your liver and kidney function. We also don't start these drugs until the patients are comfortably recovered from surgery and eating and drinking normally, which might be sort of around the time of discharge, or in the case of cardiothoracic surgery, it might even be a couple of weeks after. In day surgery patients, then we might just start it sort of as soon as everything's back to normal. So I'm mentioning this because I'm very grateful to Diabetes SA, who have supported our group with a research grant earlier this year. So I just wanted to actually acknowledge that and thank all of you who often contribute donations to research to Diabetes SA, because that goes to support research such as what we're doing and about to do. So with my colleagues, who includes another endocrinologist, an anaesthetist, and Professor Michael Roberts, who's a pharmacotherapist, we've developed a finger prick measurement to check these SGLT2 drug levels. And what we want to do is study people who are going for surgery and check their finger prick levels of the drug and see how that correlates with measurements of their ketone levels. So in other words, if you stop the drug 3 days before, how that wears out of your system and what happens to your ketones over that time. Or if inadvertently you only stopped it a day before, how does that actually handled? And then we want to use that in combination with checking the ketone and acid levels, but also checking other hormones like insulin and glucagon, and then clinical characteristics like how long you've had diabetes, other drugs, your diabetes control, your age and kidney function. And we want to come up with an algorithm that can then help your doctors and your diabetes nurses to advise you on whether you're likely to get this and perhaps guide you in the lead up to surgery. The second part of our research is actually going to study people who actually have already come to hospital with this complication, and we still get, probably at least 1 or 2 a week at the moment, and then measure these same things, but these in people who have actually got the condition, and try and work out if there was any common features, both biochemically as well as clinically, that could have predicted who was more likely at risk. And then finally, we also want to offer patients who've had this complication, maybe for a very good reason, maybe in the context of surgery, but who've gone home, whose doctors may wish to restart the drug. Because don't forget, these drugs are preventing heart attacks and improving your kidneys. So we wouldn't want you to lose the benefit of the drug just because of a predictable event which is now over. On the other hand, maybe that's not wise. Maybe everyone who ever had this episode should never go back on it. We don't actually know the answer to that, and there's no definite guidelines on that. So we will be offering people who have got these complications the opportunity to restart it under close supervision to see whether or not, when you're otherwise well, you can continue to take these drugs. So just to sort of bring this talk to an end, I want to remind you that this is a very important class of drug. Essentially, the GLP-1 analogues that Chris mentioned and the SGLT2s have revolutionised our treatment of type 2 diabetes. This has all been, in the last sort of 5 to 10 years. So they don't just work on glucose like the old drugs used to do. They improve weight, they reduce blood pressure, they don't cause low blood sugar, they improve heart and kidney health. But you just have to be aware of what the side effects are, as with any drug. That's the urinary infections and thrush, and also this risk of euglycemic diabetic ketoacidosis. And that can be, we think, prevented to a large extent just by taking appropriate precautions and stopping the drug appropriately, depending on the type of surgery. And as mentioned, our research is focusing on how we can develop this further. So thank you very much for your time, and I'm happy to take any questions on the talk.